Thank you for joining me, Dr. Amir, here at Fortis Health for another insightful session on the topic of testosterone replacement therapy. So obviously, like in any therapy, you have to look at the risks and benefits. So we spoke about the benefits being the muscle development, the lack of, or rather the loss of fat or redistribution of fat, mindfulness, energy, libido, erections, and all of those compounding effects that will have other effects on one's lifestyle. So those are the benefits. Now look at the risks. So when you start testosterone therapy, you need to make sure you've done not only your due diligence regarding the blood panel, regarding testosterone, the hormones that relate to it, but all the other blood tests as well. So when one is taking testosterone, it can have compounding effects elsewhere in the body, but then those effects will be mitigated over the basis of monitoring them over time and managing those risks or those side effects that appear over time. Now, before we begin talking about the risks, let's make it very clear. Testosterone replacement therapy, listen carefully to the wording, replacement therapy. Now, let's think about testosterone. It peaks in and around people between, say, 18 and 28, say. We can shift it to 21 to 30, but roughly that is the main age group where testosterone is really good. And I'm sure you'd agree with me. So that cohort of patient where testosterone is probably at its peak, plus 20s, 25, maybe even 30, and in some cases, maybe 35. Do you see cardiovascular outcomes? Do you see cerebrovascular outcomes? Hence, do you see heart attacks and strokes? Rarely, unless there's a genetic predisposition or congenital cause for it. But we never see men or young men in that age group having a large group within that group having heart attacks and strokes. You don't see things like prostate cancer. You don't see things like liver problems or problems with the blood or problems to do with to do in the internal systems. So we have to keep that in check. If testosterone was truly a villain, was the bad guy, then really we would see a lot more people between, say, 18, 19, 20, up to about 30, 31, presenting medically daily in the emergency department with all of these confounding factors. And it doesn't happen because testosterone is not the bad guy, it's the good guy. And if we make sure we keep patients within the physiological realm of their own parameters, to be fair, those side effects shouldn't come back, shouldn't really fulminate. However, we have to talk about them. So one of the first things that can happen is your red cell count starts going up, which is great because testosterone improves the number of red cells through a process called erythropoiesis. Basically, increased production of red cells in the bone marrow. That's great. You've got more red cells, more hemoglobin, more oxygen, you feel great. However, your blood can become thicker, what we call looking at the parameter of hematocrit. Now that thickness, hypothetically, has never happened. If the blood would get so thick, there's a chance of causing a blockage or a clot. Now, I have never seen that ever. And there's many patients who've got already heightened hematocrit levels. Patients who actually live in the mountains, a good example, with high altitude. Because high altitude means low oxygen. Low oxygen then forces the body to produce more red cells to compensate for that mechanism. So those people who live in the mountains, we don't really hear about mountain folk having strokes and like thereof. But nonetheless, when hematocrit climbs, we have to not only monitor, we have to mitigate the risk. So what do? If that were to happen, one of two choices. You either can reduce the dose of testosterone, increase or rather the duration of administration of the drug, or in some cases, you can do venesection, which is called blood donoring, which we do anyway, which is great because now it's a two-pronged approach. Not only do you get to benefit from therapy, the excess of blood that you have, you can benefit someone else with it, on the condition that you haven't got any other ailments or contraindications from giving blood. Okay. Another possible side effect is as testosterone climbs, your estrogen levels can climb. Again, remember, these are microdoses of testosterone taking on a very small amount on a regular basis. So again, these side effects shouldn't really fulminate, but if they do, once again, you're monitoring and you mitigate those side effects by monitoring, obviously, first and foremost, and then incorporating adjuncts or techniques that can actually help reduce the outcome. So estrogen can climb. As it climbs, it can cause certain effects. It can put pressure on libido. on erectile function, on your mindfulness, and in some worst case scenarios, if it climbs too high and it's not being monitored, you can end up with gynecomastia or breast tissue development or formation inside the breast tissue around the male chest wall, what we call gynecomastia. Now, again, if a clinic has allowed that to happen, that's quite disturbing. That shouldn't happen. That should be monitored and engaged. And don't forget, blood testing is happening every 2 to 4 to 6 months regularly throughout the year. If that were to happen again, you can either reduce the dose of therapy, increase the duration of therapy, or introduce a drug called anastrozole, or from the family of the aromatase inhibitor drugs, which actually helps reduce the productivity of testosterone to estrogen, because estrogen derives from testosterone. Another interesting thing that can happen with testosterone levels rise, again, happens very rarely. You can actually become a tad bit more thinning of hair on the top of the crown because of something known as DHT, dihydrotestosterone, which comes from testosterone. It's the good stuff that makes you strong, makes you fit, makes you healthy. It's basically the testosterone that you really want. That's the outcome. And it also, by the way, the testosterone makes you really hairy. Chest hairs, shoulder hairs, back hairs, ear hairs, nose hair, facial hair, the whole lot. However, interesting enough, it's the same testosterone that actually causes thing on the top of the head. Now, I obviously have seen this, and when you see this, patients can do one of two things. Again, reduce the dose, increase duration of administration, or you incorporate very simple techniques like minoxidil and finasteride. Finasteride being a testosterone or DHT blocker by blocking 5-alpha reductase, which is the enzyme that turns testosterone into DHT in the scalp, and using minoxidil, which helps the blood flow to the scalp. And I've seen many patients who will start therapy, might get some thinning, put them on this topical head preparation, and within a few weeks, the hair growth has come back to a certain amount. But don't forget, you were eventually going to thin. So TRT can accelerate that thinning, but mitigations, like we just said already, reducing dose, increasing duration, or not doing any of that, and using topical therapy. So other side effects or risks that one is taken into consideration with testosterone replacement therapy is there are certain pathways that you really can't use when patients, if someone says that I have low testosterone, you've checked them, they have low testosterone, but they want to maintain fertility, actually testosterone itself can reduce fertility. Now that's an actual subject matter in itself that we can talk about and how it works. But generally the point is there are pathways where you can actually induce your own testosterone levels, what we call endogenous, internal testosterone levels, and also maintain fertility. When you take testosterone externally, you'll actually put pressure on your internal own natural testosterone processes, and as a consequence, you can actually put pressure on your fertility. Other things that one has to watch out for is, again, remember, this is hardly seen, but it has to be spoken about, patients who might develop acne. So we find that people who have very bad acne in their youth might get marginal acne development, but it only ever happens when you go outside of the physiological zones. So patients or people who take what we refer to as PEDs, or performance enhancement drugs. So they take testosterone at anabolic doses, where you see people taking 3, 4, 5, 6 times the dosage of a normal TRT dosage, will develop those outcomes because you're going into the superphysiological zone, the zone that really we don't know much about, and can induce those effects. There are a certain number of patients who shouldn't be given testosterone, and those are patients who've got active prostate cancer, patients who've got active gynecomastia, so breast tissue development, or have even male breast cancer. That's a true presentation. 1% of all breast cancer is male breast cancer. Patients who've got severe sleep apnea, and what we say is not severe but rather untreated sleep apnea. So if it's treated, you can treat them for it. And there is one more cohort who've got severe heart failure. Not because testosterone causes heart failure, we know that's not the case at all. If anything, there's cardiovascular benefits to testosterone. It's because if you've got severe heart failure and you suddenly get a boost of energy and a boost of libido and you feel really good, there's a chance that you can actually put that patient in a compromised state, because they want their energy internally systems go up, but their body or their physiological organs can't take that particular level of energy, and it can actually cause compromise on the heart's function. Outside of that, there's not many other things that we look at when it comes to risk and risk mitigation in terms of TRT therapy, but these are the things that we'll be looking at through your management of your TRT therapy, in terms of looking at your blood processes, looking at your blood panels rather, looking at your physiology, looking at your testosterone levels, and looking at all the other organs that have to manage your body's health. So things like your kidney, your liver, your full blood count, and all these things that we take into consideration when you're managing you throughout the pathway. And I think that's really key. Now, just a quick topic on prostate. Now, people talk about prostatic cancer. There is no evidence whatsoever that testosterone causes prostate cancer. If anything, what they're showing is that as your testosterone levels fall, the correlation of prostate cancer rises. But again, you can't say that testosterone deficiency causes prostate cancer. That again cannot be claimed. That's just a correlative, figurative statement. Okay. However, if you have active prostate cancer, one should not be taking testosterone therapy at whatsoever. That's a contraindication. But what we do know is that actually testosterone replacement therapy actually helps with lower urinary tract symptoms, so all the prostatic symptoms we spoke about. And again, there can be a marginal increase in one's prostate size, which is due to the development of things like can develop into prostatic hyperplasia or BPH. But that very, very seldomly happens because you're putting that patient in a physiological replacement zone. I just want to constantly remind you that we're looking at replacing what is lost and optimizing what is insufficient, and that's the key, especially when it comes to looking at benefits and risks and risk mitigation.